And what we explained to them was that, we had the technology to do that. We could interface with all of their systems. We could build shared electronic health records, and we could show them the information about the patients that we had. The problem was in their policies and procedures that didn't let them use that information and didn't let them put that in. And all of the barriers and obstacles to developing this system 15 years ago were barriers and obstacles that were a matter of practice and policy within their organizations, not the technology. And the CEO of the hospital system sat back and said, I always just assume, because I don't know the technology, that must be the problem. And when she saw that the problem was not the technology, they immediately cut through all of those boundaries and barriers, and we began to make productive use of that particular system. We'll flash forward about 10 or 12 years into the future. I was sitting, and I mentioned last night, and I've written a book about this called Losing Tim, about my son's experience with schizophrenia, which he's had for 25 years. Most of the last 10 years he spent in that revolving door of homelessness, occasional hospitalization, and frequent incarceration, most recently in San Francisco. And as I was writing the book about Tim, a short version of it was going to be published as an essay, first in Health Affairs and then the Washington Post. And they said, can you get formal permission from Tim, who was homeless, so that we can use his name, to understand that he is willing to let you write about him? And I said, sure, I'll be willing to try to do that. I contacted his service provider in San Francisco at that time, explained what it was I was looking for, and she said, well, I'm not going to ask him to do that. And I said, well, why not? And she said, well, I'm not comfortable asking him if he will give you a release so that his name can be used as part of this story. And I said, you're not comfortable with that? I'm not asking for one thing or another. I'm just asking if you'll put a release in front of him. I'm not comfortable with that. I said, he has a lawyer now, right, a public defender. She said, yeah. I said, can I have the name of the public defender? She said, sure. And so I contacted the public defender, and I explained what I was looking for. And she said, of course, I'll bring this release to him. He can decide whether or not he wants to sign this thing. And I said, that's terrific. That's all I was asking, but I want to tell you, his service provider said they wouldn't do that. And she said, well, I don't infantilize my clients that way. And the policies and the procedures are really what has gotten in the way of the science and the technology that we've been hearing about. At Mental Health America, like NIMH, we're all in on Before Stage 4. We started that a year ago, and it's really taken root. And one of the calls to action we have around our Before Stage 4 initiative is online screening. When people say, what can I do? We say, go online. You can take an anonymous screen free on our website. As of next month or later on this month, we will pass the 1 million mark in completed screens on our website. People can use those screens, and then they can move to what it is they need beyond that. And what people are increasingly asking us for are applications. They're increasingly asking us for worksheets, online tools, kinds of things that they can follow up with on their own. But the major barriers and obstacles we will continue to have for people following up and making sound use of these tools and obstacles is that we live in a society where the public policies that are currently built around behavioral health services are public policies that date back to 1970 and the 1960s. They did not anticipate we would have an Americans with Disabilities Act when they passed 42 CFR Part 2 that said we're not going to share behavioral health information same as we share regular health information. They did not anticipate that we would be living in an electronic world when we passed the Americans with Disabilities Act 25 years ago which changed the way we would do things and made possible the foundation of the integration of health and behavioral health services. People today are afraid of what the technology may bring, afraid of what the science may bring, when we need to be embracing what the technology and the science can bring, and we need to be making it possible for individuals to stay in control of their own health, their own behavioral health, and the information around that, the information they care to share with providers and others when they want to share it, in the form they want to share it, and not continue to place barriers and obstacles. Because if we don't do this, if we don't move into the 21st century and embrace the opportunities we have to use science and technology as we know them today, and not as we knew them back in 1970, we will lose the opportunity to change the trajectories of lives of people who are concerned about their behavioral health. 3/4 of the people who go to our screening site are female. More than half, 2/3 of the people are under the age of 25. 2/3 of those people say they've never been diagnosed with a mental health condition before, but 2/3 of those people screen as positive or moderate to severe for the condition for which they screen. There is need out there. There is demand for other services and products out there, and we need to take away and remove the obstacles to people being able, at the earliest stages, before stage 4 of the mental health or mental illnesses processes, at the early stages of these things, to be able to take advantage of the opportunities to change the trajectories of their lives, and we need to support them in doing so. So that's what we're going to be doing, and that's what we're going in the future.
Well, hallelujah, right? Thank you, Paul. Linda?
Yeah, first of all, thank you for having me here, and congratulations on the 100th anniversary. Congratulations to Linda and to Henry for what really is a timely and exciting conference. So I'm very pleased to be here. When I thought about this, and I used this analogy last night, it feels a little like a few weeks ago, my husband and I were at a casino. And I play blackjack, but before I did that, I went over to the baccarat table, right? Because they look like big, heavy rollers, and I'm always like excited about what that means. But I don't know anything about baccarat, so I couldn't play it. And it's a little bit like being here. I'm interested in everything, and certainly the National Council is interested in all of this, but it's somewhat new to us. About 18 months ago, we held an eHealth Summit where we actually had some of the people who are here at that summit, including Big White Wall, which is an affiliate member of ours, M3, and we did that with The Atlantic, and it was kind of the beginning of a journey for us. But for us and the members and the million staff that work in those member organizations, this is a learning process. And when I thought about it, I thought about, well, how do we help accelerate that? Because, you know, I'm quite practical. I like to get down to what can we really do. And the first thing I thought of is mental health first aid. It's something we're involved in, and Maryland MHA is involved in. And as we think about the future of mental health first aid and the kind of training people get, it's a CPR, it's a literacy course. We've trained 500,000 Americans already. How do we begin to introduce some of this thinking and some of the malleability of the brain in that course? The other thing I began to think of is we have something called Certified Community Behavioral Health Clinics, which are going to be in 8 states. They're going to standardize treatment. They're going to standardize what you can expect. They're going to measure outcomes uniformly. And they're going to have a different payment system. And it may allow for the payment of some of the things we've been hearing about for the last 2 days. And then I thought about it in a bigger context. The context of the history, really, of our members, some ways my own career, some of you out there. You know, our member organizations, both the hospitals and the community centers like yours, Jeff, began in philanthropy. Catholic Charities, Jewish Family Service, Protestant welfare agencies, and then we went into an era which was totally government supported. And we have member organizations, 90% of their income comes from government, either through Medicaid and Medicare and government grants, very little else. We think now we're entering into what one of our extender staff calls the not-for-profit millennial. It's really an organization that is much more business focused. And last night, when I had the pleasure to be with Henry and some people in the Kennedy Forum, it was businesses that were at the table. So how do you now marry those businesses with organizations that come out of a history of philanthropy and government support? And I think that's part of what we do at the National Council. So when I think about our performance improvement initiatives, our technical assistance, the consulting we do, the leadership learning academies we have, all of this has to start being incorporated. We have not incorporated much of it. The other thing that it makes me think about is our other arm. Everything we do, we know that good new practices have to be supported by changes in policy. So Jeff, how do we introduce this to our board, to our state associations? How do we help move this along? And finally, a few years ago with Henry's help, we began to introduce some of this technology at our annual conference. So we're going to go back again this year and begin to do that. We have about 4,000 people that attend that conference from all across the country. Our board also is all across the country, elected members who tend to run big organizations. They're thought leaders, the same kind of people that come to the conference. And so I think we have an obligation to be helpful in bringing people this very exciting new frontier in many ways, and to participate in what we just heard from the last speaker, helping members and the 10 million people they serve begin to not only know these, but rate the usefulness of these various products. So I'm delighted to be here, and I hope we can help.
Thanks, Linda. Henry?
Great. Well, I also I want to thank Linda and her staff, and John Kamak, who's here, and Jeff and others to help put this conference together. It's really you've got some who's who of the leadership in the technology field here. The Kennedy Forum, you heard this from Patrick Kennedy yesterday. I'm not going to try to repeat all that, but there are like 5 areas that the Kennedy Forum feels they could be helpful, frankly, in supplementing and partnering with leaders like Paul and Linda's organizations and other national groups to try to accelerate policy and reforms in the behavioral health system in the U.S. over the next several years. So one of those is the parity bill, which you've heard a lot about. And that's key to full implementation of this federal parity bill to make sure we can pay for these new technologies and treatments in the same way you would pay for a new drug for cancer and a new drug for heart disease or a new intervention. The second area of the Kennedy Forum, which is an area that Linda's group has really been out front about, and some of the other groups have, national groups, is provider accountability. And the Kennedy Forum's coming out with a policy paper on this next week, actually, to try to encourage that every provider, be they an internist or a psychiatrist, psychologist, or a community health center, use a standardized tracking outcomes instrument whenever they treat a patient to improve accountability and transparency. That also, I think, will improve use of new technologies because most clinicians are not using a quantifiable standardized instrument to track progress, so they're not picking up all the time whether the person's not doing well. And in the mental health business, because and substance abuse, we don't have a biological marker. You heard our biomarker panel yesterday. So we don't have a brain measure ahead of time that will say this drug is likely to work or this is like a psychosocial. So the nature of the practice, you have to keep changing and trying new things depending on whether the person's progressing. The third area is trying to improve the collaboration between the medical system and the behavioral system. I think as we look at some of the lack of success of the behavioral health system, one of that is the majority of people who get their care get it in primary care. They never see a specialist. So more than 50% of everybody with a substance abuse or mental health problem, they never see a special mental health system. They go to their primary care, and we know that almost measure after measure that less than 13% of the care that's delivered in a primary care setting meets the minimal standard of evidence. So how are you ever going to change the metrics on suicide or better outcomes if more than half of the people never see a specialist and they get substandard care? And that's a practice that we have good evidence on, could be implemented, and I know Paul and his group's been pushing this, so the Kennedy Forum is weighing into this to try to escalate the implementation of that. And the fourth area is technology. So why do we need new technologies? Well, first of all, I think as Tom Insel may have said yesterday, he's been very public about this, the former director of the National Institutes of Mental Health, is we have not had a new psychotropic drug compound, novel compound, for 3 decades. I have over 100 plus psychiatric meds, but they're old. And most of our psychosocial treatments are old. I mean, they've been around for 3 or 4 decades. When I trained as a psychiatrist, it's over 40 years now. I guess I got to update my resume to date
It's hard
myself.
to write that
right,
40.
Right.
Over 30.
Yeah, over
Right,
30, that's
exactly
better.
right.
I should have stuck with my little year thing. The cognitive behavioral therapy was a standard in the field then. Well, what areas of medicine are still using the exact same treatments day to day that they had 4 decades ago? Not too many. So we have a problem, a lot of what we're all trying to do, the Kennedy Forum, Paul's group, Linda's group, is trying to do a better job with the things we know work, right? And like coordinated care, evidence-based practices, doing things with primary care, et cetera. But this conference is dedicated to new treatments, right? And what are new ways to approach and deliver services? Because we all know, as family members, friends, and patients, and whatever our organizations are, a lot of people get the best care we have. Many, many people. It's not a financial problem. They go to the best psychiatrist, they go to the best program, and they don't get better. So there's a lot of people in that situation, and that's what this conference is dedicated to doing, is identifying those technologies that are having a new way of treating people or a new way to outreach to them. And I think that's the promise of this, and that's what I hope all of us will be making sure we get implemented over the next several years.
Thank you, Henry. So I've been here for the past 2 days, and many of you know that I love new technology. I love this stuff, not just because of it being shiny and exciting. It offers a lot of hope, and for me, that's one of the things that's always driven my career and what I wanted to do. But I want to go back to a question that you guys are sort of skimming along the surface at, that I hope provokes some thinking here, which is, Linda, you mentioned earlier that we're in a philanthropic genesis, that we all got into this. Our organizations got started in sort of a grassroots, sort of a goodwill effort. The business world is intersecting with us. The models of care that we had, Paul, you talked about simply just getting an authorization to get a release of information, and what a barrier that's been. And I'll say this, running a large community behavioral health organization, which I think is fabulous, but am I a dinosaur? Is this model that I have, are these technologies going to disrupt not just the method, but the structure at which we provide these services? And I'd love to hear any of you want to take that.
It's an interesting question. Last Friday, I was in Massachusetts with all of the health plans that operate in Massachusetts, and it was the same similar discussion, which is, are insurance companies a dinosaur? Hospitals certainly have now become systems and bought each other up. Some of them are becoming insurance companies. I think we're in a time of turmoil. This is the first time in my career, which is, of course, like 40 years, where I actually spend time talking with private equity companies. Right. I mean, as a social worker, who ever thought, I'd know about, bundling the different purchases you make and then in 5 years, turning it around. I don't know if you're a dinosaur, but I know two things. One is you'll always have a job because behavioral health is hot. And I know the other thing is that who you work for may be different. Right. And you're an example of that. You're part of a bigger network. And I think that is the way it's going. Whether it's good or bad, I'm not sure, because in some ways it's more distant from the person in the community. Mm-hmm. So like everything, it's a mixed bag. I think just one more thing, which is, like every other industry, technology will replace people. I haven't seen a bank teller in years. I think the same thing will happen. It will transform healthcare and behavioral healthcare.
I would respond a couple of ways. Given the unmet need, right? So we have 10 times more people in jails and prisons than we do in psych hospitals with serious mental health and substance abuse problems. Given the undertreatment in primary care, given the shortage of psychiatrists and other, I don't think you guys will be out of a job for a long time. But I hope what changes is you will be introducing newer treatments and technologies, right? So that some of which will make you more efficient and may allow you to lay some people off or reassign them to do something else and meet other unmet needs. But a lot of our field, I've been in this field a long time, is spent on reorganizing and better linking services. And that's very important because that's part of, as Paul was pointing out, those are big things that you could do that closes treatment gaps. But not enough time is spent on let's introduce new treatments. So we've heard a number of those here. This isn't all of them, right? But hopefully, and it'd be really important, I think, for Linda's group. I don't know if people understand this, but the National Council represents the largest provider association in the field, right? It's much bigger than the two APAs or the two APAs and NASW put together. So for you all to take a leadership role in rolling out these newer treatments, it would be critical for this ever to reach patients. There is, though, it is a really nice thing to see the technology world coming into our area. And they are going to help us, I think, drive some of the barriers, like pushing the FDA, who we're going to hear from later, pushing CMS, pushing some of the payers, adding that kind of efficiency that they're adding to other industries. And we should be welcoming that. One of the reasons we had this conference, I don't think Zach Lynch is still here, is you heard him yesterday. He's been a leader in this field. He created a Neurotech Industry Association to bring together all these companies. And so he has an annual conference, a neurogaming conference in San Francisco every year, and he has another neurotech thing all around the world. And I said, well, we need one of those on the East Coast. And he said, well, all the smart people are on the West Coast, so I don't want to bother them on the East Coast. He said, look, all the tech people are over there. I said, yeah, but there's a lot of power on the East Coast, so maybe you ought to pay attention to this. So that's kind of what led to, let's have a cutting-edge conference over here. And I think the lineup we've had for these 2 days is equal to or better than what Zach has set up. So we'll create a little...
Whoa! That's great.
Paul, anything you want to add to that?
Yeah, I think that your question was loaded.
Yes.
Because you used the word disrupted. You know, will this disrupt that? And I want to play, to take off a little bit on Henry's point here about the opportunity. If I were your competitor sitting here and you asked the question that way, I'd be thrilled, because I'd be saying, this guy feels he's going to be disrupted. And I see an opportunity here. And I think that people too infrequently understand the opportunities that present themselves to there's organizations. There is so much science to embrace. There's so much technology to embrace. There's so many opportunities for people who are sitting at the cusp of this to say, I can change the way we do business. I can take advantage of this new approach over the course of the next 5 and 10 years. And I can make money off it. I can become more powerful, and I can give better service. I can do all the things that I set out to do. But too many people are living back in 1970 when these organizations started as community-based organizations, living under the rules they lived under, relying on the government for all the support that they were going to get. And just because that world has changed, that world changed a long time ago. Now people are beginning to catch up to it. Like I said, 15 years ago, we're doing with shared electronic health records. Technology was all there. Anybody could have embraced it and said, that's going to be us. And the few entrepreneurs that did have made a lot of money, and the private equity people who invested in them made even more. But I think that's the way to look at it. It's so long as we think about these things as disruption, I think it makes us resist. And some could say that in the last year and a half we've disrupted Mental Health America. I think we've moved in a lot of positive directions, a very productive way, and I think the results are there.
Well said. Yeah, I think sort of adding on to this discussion, which is that we've had a lot of side conversations during the breaks around this, and I actually asked a question about this yesterday, which is everything from the use of gaming as a technology to the use of having a mobile app on a cell phone that can really drive out some exciting results. But many of the folks that we serve are poor, are in communities where access to this technology is limited. How are we going to surmount that, to be able to adopt these technologies throughout our mental health community?
Well, I think while we have a confidential discussion here, right, in a public setting, but there are a number of issues that get in the way of faster adoption of these technologies. We've talked some about reimbursement. We're going to have a panel this afternoon on regulation and can we speed up FDA approval where they're playing a role. But one of the biggest problems is provider resistance and lack of interest. You heard that from a couple of speakers yesterday. I see that all the time. Some of these technologies have been out there for a decade, okay? And you talk to a psychiatrist, psychologist, a community mental health center, they don't know much about it, and they don't seem that interested. I think there's several reasons for that. One is education, but other is the lack of competitive, which Paul was referring to, lack of competition in our field and the lack of outcomes. So this is a problem for the whole healthcare field. So it's a little hard to compete when you don't know what's Mosaic's outcomes versus somebody else, where they might, if there was a little more transparency on effectiveness of providers, whether they're solo practice or an organization, where they'd say, well, you know, I might better get some of this new technology. I need to do it quicker, better, faster, more effectively than what I'm doing today. You heard this from the biomarker panel, right? Well, there are several companies that are offering these biomarkers today. They've had huge resistance to anybody wanting to use them. Believe me, because I help one of them. I have a financial relationship or an advisory relationship with one of them, CNS Response. And so I've been trying to help them for a while. Talk to a lot of psychiatrists, say, oh, yeah, I'm giving them meds, but I don't know, that's new, I don't want to do it. So you heard that from Gina Mind, you know, their medical director. So my question would be partly, what could the field do to get some energy here and interest in using some of these technologies that are there today?
You know,
Go ahead, Linda.
I was going to say, you're talking about the difference between Kodak and Fuji, right? Kodak didn't transform and basically is on its last legs, and Fuji did and used the same technology they had to take pictures to do lots of other things in the digital world. So I think that there will be people who are and are moving ahead. I think we will have additional transparency, but I also think we have to acknowledge that, in fact, even simple things like electronic health records still cannot talk to each other. So sometimes technology disappoints also. So we have to be aware of that as well. But I do see we will always have early adopters, and the way they're doing it and trying some of these new things is usually with money they're raising, because regulation and payment lags behind, Henry. So I cannot bill for use of things like Big White Wall or MyStrength. I can only bill for a face-to-face. Now, if we move towards global payments and I have some flexibility and government doesn't get scared and say we're giving you too much flexibility, then we may be able to see some faster embracing. You know, today's leader has to be fearless but not reckless. But not everybody's fearless. So I think it's a bell curve, and it has been in every other industry. It will be in healthcare. Healthcare is more chaotic because it is a business. The other thing that not-for-profits don't have is they don't have capital. So when you are a business and you're going to do a new service line, you're going to introduce a new product, you raise hundreds of millions of dollars sometimes, either through private equity, venture capital, go to the bank. Our not-for-profits don't have that, so they're slowed down. But I think we have enough people who are just bullying their way through that you will see this take hold. And I think this conference that, you know, Linda is put together, I think signals that it's come of age.
Paul?
Again, I think, just to add on to some of this, it's that I don't think it's the problem here is individuals who are poor and therefore don't have access to things they need. I think many people in America who are poor still make available access to themselves to things they want. And many people, I think, want some of these tools, and I think want some of these services. So I think, again, the resistance to this is more institutional based than individual based. I think the resistance comes from people who benefit from the status quo. I mean, if you can make enough money, you know, if you can make a profit, if you're a for-profit, if you can pay your bills and just not run at a deficit these days if you're a nonprofit, then you really kind of want to stay there, because, again, a lot of people are just, you know, risk averse about that, you know, because we know what it's like when you stop,
Yeah, I'd
you know,
like to,
balancing
I'd
the
like to
budget.
piggyback on that.
So yes, I would say that's, you know, it's as you bring these things to scale, bring these things to, I think that's the resistance.
And Henry, before you answer, I just want to also invite people, if you have questions, come on up, stand in line. We'd love to take them. So if you're thinking about something, get up. We'll pick on you.
So
Henry?
let me piggyback on Paul and disagree a little bit with Linda on this.
But
I don't
was
think
agreeing
this-
with Linda.
Well, I'm agreeing with you, right? I don't
Well, I'll
think,
disagree with you,
Yeah.
so you can.
I like when Henry disagrees. He's one of the most fun people to fight with anyway.
I love it, right. This is a problem for the for-profits and the nonprofits. So see Gary Kagan out there was on the investor panel, is invested in behavioral health services. There is a tremendous amount of money being made now by the acute hospital sector and residential treatment, intermediate levels of care.
Agreed.
I'm not saying your communal health centers
You're
are
right.
making a lot of money, but in the other levels of care, and they're just as resistant to the technology, okay? So when I'm saying provider, lack of education, willingness, and motivation, I'm talking about the whole field, not just the nonprofit sector. There's a lot of resistance there. I can't tell you how many people I've gone and said, well, hey, they got this new technique or this way to measure this. They're saying, well, I'm busy. So what you were saying, Paul, I'm busy, I'm interested, I'm surviving, or I'm making money today. And part of that's the lack of outcomes, right? It's like we can't measure the success very well, so it's hard to come out. This is a problem with all of healthcare. But anyway, so
I agree with Henry, actually. There are certain sectors, and investors are investing in those sectors. Residential treatment for addictions,
right.
Private psychiatric hospitals that are for-profit have tremendous amount of money that's being poured into them.
And they're doing the same thing they've been doing for 40 years. So
Not
don't
only
get me wrong.
that, they actually talk about those settings as real estate rather than treatments.
Right.
I think the other thing this discussion does is it brings us back to treatment, whereas most of the time I'm discussing moving really the deck chairs around how we should organize
Absolutely.
payment systems.
I think that's probably the most important.
Let's take some
conclusion
questions
of
from the audience. Yes, ma'am.
Hi, my name is Marsha Marshall. I'm a consumer, I'm a caregiver, and I'm an advocate for older adults. I am a member of the Maryland Coalition on Mental Health and Aging. You have not talked about old people once in a day and a half. Not once. And Medicare pays a lot, and it pays each of you a lot. So think about older adults and the issues that they have. The second thing is that the IOM did a study about workforce issues, and there is not enough workforce. All the technology is great, but there are not enough people in this profession at all levels to carry it out.
Any reactions from the group,
Well,
Henry?
First of all, I don't think that's totally accurate. The first speaker of the day, Majid Fahuti, talked all about dementia in older people and intervening in cognitive impairment. And some of the apps that Michael Knable was talking about are for cognitive impairment of all ages, but particularly for older adults, which is a number of the cognitive games that are out there are aimed at cognitive impairment in elderly adults. So I think I think there's some of the focus has been on that. These are technologies for every age group. So I don't think it's an age issue. But I'll go back to your question, Jeff, on the workforce issue. We do have a shortage of specialists in particular. And that's why I don't think anybody's going to be laid off by these technologies. If we make ourselves 5 times more efficient, you probably would still have a shortage of specialists. So,
Anyone else in the group want to? I mean, the only other I would just add to it is that some of our payers may be paying a lot of money, but to be perfectly blunt, I can, from my own experience, they're paying for the wrong things. And so I think in many ways we incent the performance that we're getting. And I think we have to do more to move towards models. Linda talked about certified community behavioral health centers, the flexibility around utilizing these technologies, and get away from just the endless requisite for CPT code delivered encounter.